Hello, my name is Vincent Clark. Welcome to the presentation of Huntington's disease. The group consists of myself, Miles Dumash, Chris Jarsky, and Philip Cunha. So let's get right into the case. We have Mary. She's a 52-year-old with a diagnosis of middle-stage Huntington's disease. She had recently had to leave her job. She worked as a nurse due to an increased amount of choreic movements, so she has challenges with upper and lower extremity control. It's led to some falls as well. She currently lives alone, and she does have a son for some support, but he's not around all the time. She is on some medication for some of the symptoms of Huntington's disease, and she's right now concerned about being able to do her activities of daily living, living at home, and if she needs any assistive devices. So I think we've been pretty fortunate to have several lectures on this specific disease. To give a brief overview, it's essentially a fatal genetic disorder, and it does cause a lot of progressive breakdown of nerve cells in the brain. Initially, it affects the basal ganglia, which has a lot to do with motor control, but as the disease progresses, it can certainly affect other structures. It affects more than 30,000 people in the United States, and as of right now, Huntington's disease has no cure. The average age symptoms emerge is actually around 40 years old, and the average life expectancy once you're diagnosed is around 10 to 30 years. It is interesting to note that most of the deaths occur from pneumonia and falls, so this is something that we can certainly be aware of and something that we as PTs can do a lot to prevent, especially with patients that are in the middle stage of the disease. So I don't know about you, and you probably know by now that I'm more of a visual guy. So I put this in. It kind of resonates with me because of the amount of atrophy that you can see between both brains. On the left is normal, on the right is the one that's affected by the disease. You can see the enlarged ventricles as well as the atrophy of nerve tissue in the basal ganglia. So it makes sense, especially when we go into different impairments and symptoms, which leads me into my next slide. So there's a lot of symptoms that can occur from Huntington's disease, such as movement disorders, cognitive deficits, psychiatric disorders. I thought it was interesting that the most common is depression with psychiatric disorders, but it does make sense, especially with everything that they're going through. It's kind of like the chicken or the egg. What caused the depression? Is it the actual atrophy of everything going on upstairs, or is it because of the disease diagnosis and it's kind of like a following effect? So that's kind of interesting. What comes first? I don't know. Movement disorders, this is going to be our specialty and things that we're going to see, especially chorea, which is involuntary jerking and writhing movements, muscle problems, dystonia, slow or abnormal eye movements as well, so visual impairments can be certainly there, impaired gait, posture and balance, that can obviously lead to falls, and then some speech deficits as well as swallowing. So there's a lot of things going on. I'm not going to go through every single one of them, but there's certainly it's a lot of variables into the equation for sure. So I'd like to talk about the stages. In the first stage, there are some structures in the brain already being involved, as you'll see on the image on the right. Patients often would exhibit some difficulty organizing routine tasks. They'll have some difficulty coping with changes in a routine. They'll have some impaired decision-making, as well as some mild incoordination and confusion. In the middle stage, you'll see on the right image that there are some more brain structures involved and a little bit more severity, I guess you could say. An increase in difficulty working with ADLs, tough time managing their house, skilled voluntary movements become more difficult, and this is actually where we're going to be working with Mary, the middle stage, and I think it's the most impactful as far as physical therapists, that things that we can do for that stage, and I think was certainly mentioned in our prior lectures. And then the late stage, they can no longer manage their ADLs. They often require professional nursing, and swallowing and communication difficulties can certainly arise. And as you can see with that image, there's a lot of brain involvement at that point. So before we get into specific interventions for patients with Huntington's disease that we found, we do know that physical therapy can certainly help. And a lot of it has to do with the stage of the disease that the patient is in. Early stage, we can work on improving fitness, preventing deconditioning, endurance, strength, range of motion, patient ed, home exercise program, all that good stuff. Middle, this screams PTs. Balance training, fall prevention, safety with ambulation, functional training, ADLs. These are things that we can certainly work on and make a big difference. And late, you probably want to change up your mindset and some of your goals, maybe more for comfort measures. Family education important, involving the team, the support team. Environment modifications, promoting comfort, and obviously protecting the patient. At this point, I'm going to hand it off to Phil. He's going to talk about the first intervention and the study that he found.
So for this patient, we have to assess her fall risk, and we also have to see if an assisted device would be beneficial. And when looking at this disorder, we want to incorporate all the functional impairments that we might see. So in terms of PT intervention, we would look at assessing the need and fitting for the assisted device. So we're considering what is easier to use. Is there maneuverability components that we have to be aware of, so moving around the house. We also have to work with gait training, learning the sequences, as well as educating the patient. This was done with 21 patients with Huntington's disease. So this was testing ambulation, safety, and maneuverability around objects. So this was done walking in a straight path and a figure 8 pattern. If you look at the right, you're going to see that there's the footfall patterns of individuals with different assisted device and no assisted device. And it's very interesting to see how you can see that stutter stepping when they use an assisted device like a cane or a walker versus when they're not using an assisted device, and when they use a four-wheel walker, they actually have more spread out gait pattern, more normal-like. The 7 conditions that were tested were no assisted device, cane, weighted cane, standard walker, and the 2, 3 four-wheel walkers. The outcome of the study showed that the four-wheel walker was the most effective assisted device. The gait pattern showed that it was least variable. This is clinically important because a higher variability has been shown to correlate with increased falls in the elderly and those with Parkinson's disease. So this can correlate with Huntington's disease as well. Variability is always dependent on the base support, the step time, stride length, swing time, and double support time. So we're looking at reducing the risk of falls. We want to decrease the variability. Also, gait pattern was shown safer than with no assisted device, which reduced the amount of stumbles and falls. This allows the individual to maneuver around objects much easier. The patient also showed that it was easier to use a four-wheel walker. Many of the patients saw that being able to push an assisted device is much easier than having to pick up and coordinate a cane or a walker. Additionally, when we want to apply this in the clinic, we want to use this for gait training. So this means we have to find the right assisted device. So we want to use a four-wheel walker because it's manageable. It's safer, there's less variable of gait, and it allows them to increase their maneuverability around objects, which in the end should help with the decrease of falls. I'll hand it over to Chris next with the next intervention.
Thank you, Phil. So the next study that we'll go over was written by Zinzi et al. And published in 2007, entitled Effects of an Intensive Rehabilitation Program on Patients with Huntington Disease, a Pilot Study. The study included 40 patients, 23 of whom were female and 17 were male, and they were recruited to participate in 9 3-week sessions over a 3-year period of combined physical, occupational, speech, and cognitive therapy. This was done at an outpatient clinic in Italy, and it was a within-subject design. In terms of interventions on the PT side, the sort of exercises that would be used would be respiratory exercises like trying to inflate a balloon, gait training like figure 8s with or without assistive devices, balance training for static like weight shifts from one foot to another, dynamic balance training like walking with one hand behind a person's back and the other on the assistive device, and general aerobic exercise like stationary bikes. There were several outcome measures that were used throughout the study, and some of them were administered before and after the 3-week training period, and some just at the very beginning of the training period. There were the Zung Depression Scale, the Mini Mental State Examination, the Barthel Index, the Tinetti Scale, and the Physical Performance Test. Both of the last two were administered at the beginning and at the end of the 3-week session, and there was an average score increase of 4.7 on the Tinetti and 5.21 on the Physical Performance Test. There wasn't any carryover effect from one admission to the next, but also there was no decline in abilities from one admission to the next. In terms of applications of the physical therapy component, there will be things like promotion of neurogenesis, trunk and thoracic mobility, as well as inspiratory and expiratory performance increase, improvements in gait and balance, improvements in endurance and the ability to perform activities of daily living and functional tasks. The sort of setting that would be used, well, in this particular case, it was an outpatient clinic, but probably just about any clinic would do in this particular case. In terms of dosage, it was 3 years total with 3 therapy periods per year and 3 weeks per therapy period. And it would be 5 days a week at 8 hours per day, 1 day a week at 4 hours per day, and the 7th day would be a rest day. There are some caveats that come with this particular approach. The very first one is that it's a very intensive approach, and a lot of people would not be able to do it due to scheduling and time constraints. The study was published in 2007, and no one has tried to replicate it yet. Also, the exact interventions were not very well detailed, so we don't know what exercises, in addition to the ones that they mentioned they did, and how many of each exercise was performed. So now I'll hand it over to Vince for the third intervention.
So before we get into that third intervention, we just wanted to show you a quick video about an intervention that was used in the last study, more specifically weight shifts. So as you'll see in this video, Chris is explaining the intervention to the patient, who is Phil, about what's going to happen. And this can help with therapeutic alliance, making sure that the communication is on point and that the therapist and the patient are on the same page. So essentially, they're going to start with lateral shifting. And these exercises are important because it can challenge patients in moving their center of mass around. It can improve coordination, lower extremity strength, and can really transfer into some functional tasks like ambulation. So the third intervention that we found had to do with task-specific training. And this was a random controlled feasibility trial. And for some reason, I had no idea what that was. So feasibility studies are essentially implemented to determine whether an intervention warrants further investigating, and I do feel like these researchers thought that that was the case at the end of this one. So in this study, there were 28 patients with mid-stage Huntington's disease, and this really fit our case well because that is where Mary is at. As far as the intervention go, they did some task-specific training, so things like walking, sit to stand, some transfer, some standing, and this was conducted at patients' homes. Duration was 2 times a week for 8 weeks. So the results shouldn't be too surprising. They had improvements in outcome measures such as the physical performance test, the timed up and go, 10-meter walk test, 30-second chair sit to stand, and the Berg balance scale, all in turn helping to decrease risk of falls, improving lower extremity strength, endurance, increasing gait speed, and really helping out with functional capacity. So these are all great things, and it definitely makes sense. So the last intervention I'm going to hand off to Miles.
All right, so the fourth and final intervention we're going to be discussing is the video game Dance Dance Revolution, which you can see Troy here is amused with greatly. Okay, so in case you're not familiar with what this video game is, it is a game that consists of a pad with 4 arrows, as you can see in the picture below. So there's a forward arrow, a back arrow, a left arrow, and a right arrow. This pad is connected to a screen that is playing a song, and as the song plays, it will flash one of those 4 arrows, and you as the player have to step on that arrow. So just not knowing anything else, you can imagine there's probably already going to be some dynamic single-leg balance, some coordination, a lack of visual dependence looking at the screen, dual task. So you might think, this sounds like a great intervention for Huntington's. Well, here's what the research has to say. So, this study took a group of 24 patients who were all in a wide range of age, aside from the fact they were all at least above 18, and they were in a wide range of Huntingtons going from early to mid, not so many in late. The dosage of this video game played was 45 minutes, and it was done twice a week for 6 weeks. And this was done in the home setting, so the physical therapists were bringing the game to their homes to get this done. And the results were, as you can see here, positively changed outcomes with the following outcome measures. So obviously, improved gameplay, meaning they were able to start from a low difficulty to at least medium, or in some cases even difficult. We saw increased spatio-temporal gait measures. So what does that mean? That means we're talking improved step length, improved gait speed, improved cadence. So all good stuff there. We saw reductions in needs for having double support. So maybe they were starting off with 2 canes or having 2 people holding the gait belt, but a reduced need for double support with either forward or backward ambulation. And then we also saw reduced heel-to-heel base of support and more heel-toe walking with these patients. However, there were some outcome measures that did not have a significant change. So one of them was the Tinetti mobility test, and the other was the Foursquare step test. So as far as the reasons the study suggests for why these outcome measures did not change, what's suggested is the cognitive factor, because a lot of patients complained that these outcome measures were too hard to understand, to figure out. The directions were too complicated, whereas just playing the game with flashing arrows that you step on, or just telling someone to walk, that was a lot easier for them to follow. So they think that may have been a reason there wasn't significant change with those 2 outcome measures, Tinetti and Foursquare. But other than that, all the other outcome measures showed that Dance Dance Revolution, the video game, had great outcomes for these populations. So now we're going to show you a video of how to play this game, because it makes a lot more sense than the directions I'm giving you right now.
And welcome back. So in this video, Phil is explaining to the patient, who is Miles, what's going to be happening today. What is DDR all about? So using some tactile cues, he's showing some foot positions that Miles is going to be expected to perform. Now they're looking at the TV. They're going to see what's going to be happening, essentially waiting for those arrows and seeing what the screen is going to want them to do in the song. So it looks like they're jamming out to some YMCA. Miles is getting down with it. Phil's doing a good job of guarding, kind of being there for support if needed. And now Miles is going to town. He's doing different semi-tandem stances. He's working on that balance, moving that center of gravity around. Seems like he's doing a pretty good job. So it looks like Phil is really trying to challenge Miles and get that balance going. This can certainly be great for ambulation and trying to prevent falls. And it looks like Phil is giving us the thumbs up. Things are looking pretty good.
Okay, so in conclusion, what are some options we can do with Mary? Mary's trying to see if she can live at home safely, so we're looking for balance, we're looking for fall risk, we're looking at ADLs. So all in all, it looks like she'd be best fitted for a 4-wheeled walker in order to increase her independent ambulation, reduce fall risk. It looks like high intensity and high frequency physical therapy exercises would do great for her. It looks like task-specific training would help her, and Dance Dance Revolution even could help her, and that's a fun game with a lot of patient satisfaction. So all in all of these are viable treatments for Mary, and hopefully you feel like you have a few more tools for your tool bag if you encounter some patients with Huntington's disorder.
And I think that's going to do it. So we just wanted to, as a group, thank you for checking this out. Hopefully you learned a little bit, had a good time, and guess we'll see you later.